Thank you very much, and thank you very much for inviting me here, and thank you for being here. I'm going to talk about hematopoietic or bone marrow stem cell transplantation and CAR T therapy, Chimeric Antigen Receptor T cell therapy. So I was, thank you, I was recruited to Northwestern about 2 years ago to really, came from Seattle, to really redevelop the stem cell transplant and cellular therapy program at Northwestern. And I've been delighted to be here. I find Chicago's a fabulous city, and I really appreciate the rheumatologists and the pulmonologists and all of the different other doctors at Northwestern. They really are excellent at working together, and I'm here to talk about the transplant and cell therapy programs that we are developing. So I'm not going to talk about what is scleroderma. I assume that there's knowledge and understanding of what scleroderma is, but I am going to talk about some of the studies that are pivotal for the use of disease-modifying antirheumatic drugs for systemic sclerosis. And then I'm going to pivot and talk about stem cell transplantation and the clinical trials that were completed to demonstrate the role of stem cell transplant for scleroderma. And then I'll talk about the new studies that are ongoing for the T cell therapy for scleroderma. So I'm going to start off with some little bit stark and maybe scary news, but really, systemic sclerosis is essentially a fatal disease. And until recently, systemic sclerosis with internal organ involvement, with lung, cardiac, gut, kidney involvement, has had no improvement in mortality. Despite new drugs, despite efforts by the rheumatology world, there's been really no significant change in the outcome for patients with more severe advanced systemic sclerosis. I'm not talking about mild scleroderma. I'm talking about the type that's really more extensive, involves all the skin, and also internal organ involvement. If you have this type of severe systemic sclerosis, called diffuse cutaneous systemic sclerosis, about half the patients die within 5 to 10 years from diagnosis. This is terrible, and we really need to work hard at changing the landscape and changing the outcome of this prognosis. It's the extent of internal organ involvement, the extent of lung involvement, the extent of kidney, heart involvement that really influences the survival. It's not so much the skin. It's a huge detriment to quality of life, the skin involvement, but it's the internal organ involvement that results in the fatality from systemic sclerosis. So in diffuse systemic sclerosis, meaning all over the body, all over not just in the skin, the mortality rate is 5 to 8 times higher than the general population. And with limited skin involvement, there's still an increase in mortality, but it's not as severe. Really, I'm trying to focus on the diffuse systemic sclerosis, the diffuse cutaneous systemic sclerosis with internal organ involvement. So this involves interstitial lung disease with scleroderma. And here's sort of an old CT scan showing the fibrosis. Of course, the big white blob in the middle is the heart, but in the black fields, which are the lung, the white scar tissue is really this fibrosis that occurs, and the interstitial lung disease occurs in that alveolar space. This CT scan also captures the patulous esophagus and also some pericarditis or cardiac involvement as well. But it's really the lung disease that is a major driver of mortality in patients with systemic sclerosis. So the cause of this systemic sclerosis is the immune system is attacking the body, but it's the immune cell dysregulation that mediates this fibrosis or scarring or extra abnormal collagen deposition. And it is really a complex interplay between abnormal immune response and fibrosis. And the fibrosis meaning this collagen deposition, the scarring leading to this lung damage, heart damage, kidney damage. And it's really an aberrantly activated immune cells that transition fibroblasts, which are maybe normal tissue repair cells, into myofibroblasts, which really triggered the fibrosis. There are a bunch of cytokines or inflammatory proteins that are released by this abnormal immune response, but it's all of the immune cells working together to mediate this attack and damage. The macrophages are involved, monocytes are involved, dendritic cells are involved, mast cells, neutrophils are involved. In addition, there are really the key drivers of this seem to be the CD4 T cells, which are a type of lymphocyte, are involved. T helper cells, CD8 cells also coordinate in this pro-inflammatory setting, and B cells are also involved. And they really all work together to signal each other to continue the ongoing inflammation and damage. So the conventional management of scleroderma is supportive care and immunosuppression. And immunosuppression, a broad range of immunosuppressive agents have been used. In the past, it was methotrexate, azathioprine, cyclophosphamide. More recently, mycophenolate mofetil, MMF, Celcept, and tocilizumab. There are also brand names for these drugs, but it's mycophenolate mofetil and tocilizumab are probably the most current common drugs used. The original landmark study to show efficacy of cyclophosphamide, a chemotherapy drug, for the interstitial lung disease was the Scleroderma lung study. And there was, using monthly cyclophosphamide infusions, patients had a slower decrease in the forced vital capacity, meaning the ability of the lung to take a deep breath and the extent of lung expansion that occurs with the deep breath. There was a less decline, a slower decline compared to placebo in the cyclophosphamide study. However, by 2 years or 3 years or 4 years, the benefit of the cyclophosphamide was lost, and there was really no difference between placebo or cyclophosphamide, and there was no change in mortality for patients. And here's the curve showing a slight difference in survival, but after 2, 3, 4 years, no difference in survival. And yet cyclophosphamide was, maybe a decade ago, the primary treatment for patients with scleroderma and lung involvement. Subsequent study, the Scleroderma lung study 2, compared mycophenolate mofetil, or Celcept, a pill, which you take twice a day. It's a great immunosuppressive drug for many diseases. And they compared that with cyclophosphamide. And really, there is no difference. It was equally effective, let's say, as cyclophosphamide. And so because it's a pill, it's easier to take, less side effects. All of the rheumatologists essentially switched patients to MMF after this study. And yet it still doesn't change the overall long-term trajectory of the disease. The MMF doesn't. And tocilizumab, the weekly Actemra injections that inhibit interleukin-6, actually does help to slow down the progression of lung disease, but it really doesn't change the overall survival of patients. It doesn't change the final outcome of the inexorable decline in lung function in patients with systemic sclerosis. So what can be done? We need to do something better than this. So I am a hematologist-oncologist, a bone marrow transplant physician. I was focused for many years in my career on helping patients with leukemia, lymphoma, multiple myeloma go through high-dose chemotherapy and stem cell transplantation for treatment of these cancers, blood cancers. And many years ago, myself and others thought, could we apply the improvements that we've made in the technology of stem cell transplantation to patients with severe autoimmune disease that are not doing so well. And we thought, could we apply hematopoietic stem cell transplantation for patients with diseases such as systemic sclerosis? And the answer is yes. And I'm going to show you the data of the trials that have demonstrated that stem cell transplant is the standard of care for basically for patients with scleroderma, with interstitial lung disease. So stem cell transplant, just to review a little bit, is a complex multi-step procedure. It's an intense procedure. It's doable, but it's a difficult treatment. It's not an easy treatment for patients, and we have to carefully select patients to make sure that the patients who go through the procedure have the best possible outcome. Stem cell transplantation, in this case, is what's called autologous stem cell transplantation, using the patient's own bone marrow blood-forming stem cells. And we get those cells by mobilizing them, moving them out of the bone marrow into the peripheral blood. And at the time when the stem cells are in the blood at high levels, the patient undergoes apheresis, which is a Greek word, which means to take away from. And we're taking away from the blood, collecting from the blood stem cells that have been pushed into the bloodstream temporarily by combination of chemotherapy and medicine called granulocyte colony stimulating factor. These stem cells are collected and preserved and frozen in a blood collection bag until the patient's ready for stem cell transplant. A few weeks later, the patient is admitted to the hospital and undergoes what's called conditioning chemotherapy. And there are basically two choices: high-dose cyclophosphamide with anti-thymocyte globulin, or total body radiation with cyclophosphamide and anti-thymocyte globulin. And I'm going to present the data from those two trials, from the three trials that showed efficacy of these two regimens. This week of giving, that takes about almost a week to give this radiation chemotherapy or the high-dose chemotherapy and anti-thymocyte globulin. Patients are in the hospital during this time. They get the stem cells infused after the chemotherapy is out of the blood system. And that the stem cells are like the seeds from which the new blood-forming cells are brought back into the patient. The high-dose chemotherapy is intended to wipe out the immune system, totally obliterate it. And then the stem cells are given back so that you can regenerate the cells that make red cells, platelets, and the immune system. And typically patients in the hospital for another 2 or 3 weeks to recover from the side effects of the high-dose chemotherapy. Then they come out of the hospital, and it takes about a year for the immune system to fully recover after the stem cell transplantation. So this is sort of the timeline of events that happen after stem cell transplant. This procedure results effectively in a reset of the immune system, so that it's really the high-dose chemotherapy, the combination with radiation and this anti-thymocyte globulin that kills off the bad immune cells, all of those cells that they said that were aberrantly signaling and causing the fibrosis. It kills them, it destroys them. It also destroys the healthy cells. So we have to give back the stem cells from the patient, the healthy stem cells from the patient, and that resets the immune system. So get rid of the old, bring back, restart it, and regenerate a new immune system. Does this really work? The answer is yes. And it takes a year for the immune system to recover, but typically between 1 to 2 years after stem cell transplantation, there is full immune recovery, and when you analyze the immune cells that regenerate after stem cell transplant, we no longer see the aberrant signaling. We no longer see the aberrant drive toward fibrosis that was seen before the stem cell transplant, and patients wind up doing better. So there have been 3 randomized clinical trials in diffuse cutaneous systemic sclerosis. The first was done here in Chicago with Dr. Richard Burt and published back a long time ago in 2011. Had limited follow-up, but the patients in the transplant arm had better disease control at 1 to 2 years after stem cell transplant. There was a large European study that was published now a little more than 10 years ago using high-dose chemotherapy and anti-thymocycloglobulin, and comparing it to monthly cyclophosphamide. And there was an overall survival benefit. In other words, patients that were in the study and had the stem cell transplant, more of them were alive at 2, 3, 4, 5, 6 years after stem cell transplant compared to those in the control group. And that definitely showed that stem cell transplant provides a survival advantage for patients with scleroderma. And there was a US study that came out a few years later where we used the combination of chemotherapy and radiation and stem cell infusion compared to monthly cyclophosphamide that also demonstrated a significant superiority of stem cell transplant over any conventional therapy. In this case, it was the monthly cyclophosphamide. So these were patients who had risk of mortality, meaning interstitial lung disease with advanced systemic sclerosis. The European trial, here's showing the schema from the publication. Half the patients got the transplant, half the patients got monthly cyclophosphamide, and they were followed for many years. In summary, this is the overall survival, the patients alive after this randomization. And you can see the HSCT is the transplant group. The survival is better than in the patients who did not get the stem cell transplant. There was, however, about 10% of patients died early on after stem cell transplant from complications of the high-dose chemotherapy. I think we've learned lessons from those patients, and we have been steadily able to reduce the risk of transplant-related mortality since this study came out a little over 10 years ago, because we've identified what are the risk factors for this early transplant mortality and avoid sending those patients to stem cell transplant and supporting patients through the transplant better. The US trial was called the SCOT trial, Scleroderma, cyclophosphamide, or transplant trial, and this involved giving 8 gray of total body radiation, which is a fairly high dose of radiation, but protecting, shielding the lungs and the kidney because those are the most sensitive organs in patients with systemic sclerosis. So the lung and kidney got much less dose of radiation, but the rest of the body got 8 gray of radiation, which is, again, a fairly high dose of radiation, but not super high. We can give higher doses to humans, like 12 gray, 13 gray, so this is a little bit intermediate dose of radiation combined with cyclophosphamide, total dose 120 milligram per kilogram, lower than the 200 milligram per kilogram, plus this horse anti-thymocycloglobulin, which is an antibody derived from the horse, or we can also use rabbit ATG, and that's an antibody against T cells and B cells and helps to deplete the immune cells in the patient during undergoing this high-dose chemotherapy radiation regimen, and infusing the patient's own stem cells. This was compared to the monthly cyclophosphamide group. As you can see here, the patients had to be between 18 and 69, had diffuse scleroderma with poor prognosis markers such as progressive worsening interstitial lung disease with extensive skin involvement, and the disease duration less than 5 years, meaning early on in the course of the disease, and either impaired lung function or past history of kidney involvement. In this study, it turned out that patients, all but every single patient had interstitial lung disease that was enrolled in this trial. Here were the published results from the New England Journal of Medicine article, and in red on the upper line is showing the patients in the transplant group, and blue is the sort of natural history, the patients in the monthly cyclophosphamide group. And there's a definite improvement in overall survival. So if you want to be alive 5, 10 years after diagnosis of this diffuse cutaneous systemic sclerosis, and you have interstitial lung disease, you should get a stem cell transplant, is what this data shows. The long-term follow-up, with up to 11-year follow-up, showed sustained survival advantage of having this transplant. So patients who did well and survived in the red line in the upper arm and the transplant arm continued to be alive and doing well, while patients that did not get transplant continued to die of complications of progressive lung disease. So again, stem cell transplant is far superior to not doing a transplant. And the patients who had the stem cell transplant, 92% of them did not need to go back on MMF or tocilizumab or any other immunosuppressive drug. It was one and done, their disease is under control, their lungs were getting better, and they did not have active scleroderma anymore. So these, to me, are the strongest data to support the use of stem cell transplantation for scleroderma. We have long-term data that demonstrates the long-term efficacy of this approach, and it is vastly superior to anything else that is available for treatment of systemic sclerosis with interstitial lung disease. Let's compare the European and the American transplant regimens. In the European trial, there was about 10% early mortality. As I mentioned, we've made improvements in that. In the American trial, there was about 3% early transplant-related mortality. This was due to the emergence of a secondary cancer, myelodysplastic syndrome, in a patient, and they died from that complication. So this is not to be taken lightly. Stem cell transplant is not like, oh, I'll just go in and see you in a week. This is an intense procedure. There's a risk of death in doing stem cell transplantation. We have worked diligently to really reduce the risk of death in patients going in through stem cell transplant. But also importantly, after the high-dose cyclophosphamide, there were patients that did have some disease reoccurrence, evidence of disease, scleroderma disease. 22% of patients were back on a DMARD, like a drug like MMF or TOCI, or a drug to suppress the immune system because of reactivation of the scleroderma, while only 8% of patients who received the radiation chemotherapy regimen had disease, evidence of some active scleroderma disease. In other words, it's not 100% effective in every single patient, but for the vast majority of the patients, the stem cell transplant, especially the one with the total body radiation regimen, seems to be the favorable, the most effective regimen. So in conclusion, for this part of the talk, autologous stem cell transplant is superior to monthly cyclophosphamide. Well, what about MMF? What about tocilizumab? As I showed in the previous slides, MMF is not better than cyclophosphamide, it's just better tolerated. It doesn't change the disease outcome for patients with systemic sclerosis and lung disease. Stem cell transplant is superior to any immune suppressive therapy for treatment of systemic sclerosis. The stem cell transplant is the standard of care for diffuse systemic sclerosis. Insurance companies, as a result of these phase 3 trials, accept and allow patients to undergo stem cell transplantation for scleroderma and pay for it. In my opinion, the total body radiation regimen with lung shielding, the cyclophosphamide 120, and the patients that can tolerate this, and we do pre-transplant testing to evaluate for that, may be superior to the high-dose cyclophosphamide ATG regimen. And we know how to help avoid the transplant-related mortality in patients. The risk factors for complications after stem cell transplant: prior smoking, pulmonary arterial hypertension that's not adequately treated. The complications after the total body radiation, a total of 7% of patients developed a secondary myelodysplastic syndrome, and it's likely due to the radiation exacerbating that risk. So there are some caveats in recommending transplant for patients with systemic sclerosis. And in summary, either transplant regimen, both of them are effective. We try and tailor the treatment to tailor to the right treatment to the right patient. So I've presented this data. Maybe you've heard this before, and you know that stem cell transplant is effective for systemic sclerosis. Why does it work? And And really, it's what I mentioned, these initial principles, the intensive immunosuppression. It's an intensive immunosuppression with a high-dose chemotherapy and combined with radiation and anti-thymocyte to wipe out the immune system and then reinfuse the autologous patient's own stem cells. It allows opportunity to reset and restart the aberrant immune system. The immune balance or immune homeostasis becomes restored after stem cell transplantation. It takes a year, and the efficacy of this high-dose chemotherapy is that, for example, as we listened to in the previous talk, after high-dose chemotherapy, the antibody vaccine titers disappear after a stem cell transplantation. I mean, it really wipes out your immune system. You're left vulnerable for a while, but the immune system can rebuild, and with revaccination, reboosting with vaccines, we're able to restore immune responses to like the respiratory viruses and the childhood illness viruses with vaccination schema after stem cell transplant. There's a little bit more esoteric maybe, but the T-cell receptor repertoire diversity, meaning what the immune system is focused on and what it protects you from, normalizes in patients who have a good response to the stem cell transplant and patients who have recurrence. In the few patients who have recurrence of the scleroderma, it has not totally normalized. So this is not, again, 100% effective in every single patient, but it's dramatically more effective compared to not doing a stem cell transplant. Regulatory T cells, cells that are important for controlling the immune response and inducing tolerance, increase after stem cell transplantation, and these tolerogenic immune cells help to control these bad actors that were causing the fibrosis in the scleroderma patients. And with more fancy cell genetic analysis that can be now done, we see that the genomic signature profile, the pattern of what the inflammatory cells are activated against, they normalize after stem cell transplantation. So here's a little bit more data, gene expression analysis of the peripheral blood cells in patients that were in the randomized US trial. Again, comparing the patients who got monthly cyclophosphamide and those who got stem cell transplantation. There were certain patterns that emerged pre-transplant, sort of characterizing the scleroderma. There was what we could call an inflammatory immune pattern, where there were basically many genes in the immune cells that were different or quite markedly different compared to healthy immune system patients. There was a fibroproliferative, again, remember the collagen deposition in scleroderma pattern. That was maybe a later pattern of scleroderma, and there were over 3,000 genes that were different compared to healthy controls. And there was a normal-like, where it couldn't really tell a huge difference. There was maybe just 300, 400 genes that were different from the healthy, normal controls. Not patients with scleroderma, just patients without scleroderma. And so it turns out that it's the inflammatory and the fibroproliferative gene expression pattern patients, the patient with scleroderma that have this inflammatory pattern or the fibroproliferative pattern, that benefit the most from the stem cell transplant. And that's sort of shown in this busy slide, that the event-free survival, meaning survival without organ failure or without progression of scleroderma, was much better in the transplant recipients who had the inflammatory graph C or fibroproliferative in graph D pattern compared to the normal-like. And just as a reminder, there was improvements in the forced vital capacity, there was improvement in lung function, there was improvement or stabilization of diffusion capacity of the lungs in patients who had stem cell transplant, shown in blue, compared to the controls. And there was a more rapid and sustained improvement in the skin scores in the patients who had transplant, and a significant improvement in quality of life assessments in patients who had stem cell transplant compared to the control group. So stem cell transplant is standard of care. We have long-term data that really confirms this. After the initial diagnosis of diffuse cutaneous systemic sclerosis, please come and see a stem cell transplant doctor to consider transplantation for the scleroderma before the lung disease gets too severe. Because if you have really advanced lung involvement or cardiac involvement, then will not take you to stem cell transplant because the risk of transplant is too great. So, switching gears, talking about something new that's really coming down the line and that I'm very excited about, is another type of therapy called Chimeric Antigen Receptor T cells for autoimmune disease. In this is involving genetic modification of the patient's own T cells. So a patient with scleroderma, we collect the blood, isolate the T cells in the laboratory, genetically modify them with a vector, a viral vector that inserts a new gene that's called a CAR gene, and I'll explain it a little bit more in a minute. And these cells are then infused back into the patient. And those cells with this gene-modified cells now attack and destroy the B cells in the patient. So the T cells are engineered to kill the B cells in the patient. And we have used this approach as a hematologist-oncologist. We have used this approach for treating patients with lymphoma, a similar approach for treating patients with multiple myeloma. And we're now testing whether this gene-modified T-cell therapy can be effective for patients with scleroderma. So it's a partnership with rheumatology and hematology to develop a highly effective, potentially curative treatment for severe refractory autoimmune disease. So, as I mentioned, CAR T-cells have been used in patients with hematologic malignancies. There have been several trials that led to landmark trials that led to US FDA approval of CAR T-cells for treating refractory lymphoma, cancer of the lymph nodes. Sorry, this is sort of just jumping ahead without me, but hopefully it'll stop. In a randomized trial that was performed a few years ago, 2 randomized trials, CAR T against CD19 B cells was superior to autologous stem cell transplantation for event-free survival, and meaning CAR T seemed to be even better than autologous stem cell transplant for patients with lymphoma, different types of lymphoma. The FDA has approved the CD19 CAR T cells for treatment of large B-cell lymphoma, acute lymphoblastic leukemia, chronic lymphocytic leukemia, follicular lymphoma, and mantle cell lymphoma. It's also approved, a different vector is approved for treatment of multiple myeloma, and studies are in progress for treating solid tumors, data pending. And what we're asking is whether or not we can apply this technology for treating severe autoimmune disease, and I would say that maybe some preliminary data are encouraging and that it might be effective for scleroderma. So let me review how we generate the CAR T cells currently. Start off with the patient wearing the blue gown and collect the cells from the arm vein of the patient. So it's collecting the cells from the patient through an apheresis procedure or leukapheresis. The cells are shipped to a laboratory where they are stimulated to grow, and the growing cells are genetically modified with a lentiviral vector. It infects only once, doesn't infect again. It's like a one-time insertion of a gene that is now making a new protein on the surface of the T cell that directs the T cell to bind to a B cell. So it's an anti-CD19 protein on the surface of the B cell, of the T cell, that will seek and bind to and kill B cells. So in the patient with lymphoma that has a B cell lymphoma, it's triggering the T cells to kill the lymphoma. But it also destroys the normal B cells. So in the autoimmune disease patient, like a scleroderma patient, we're asking, can we use the same vector to attack and destroy all of the patient's B cells and maybe that way reset the immune system? The cells are manufactured in the laboratory, sent back to the clinic. The cells were frozen for this send back, and the patient undergoes low-dose chemotherapy, much lower dose than what we use for stem cell transplant, to it's called lymphodepleting chemotherapy to sort of allow the genetically modified T cells to temporarily work in the body, and the cells are infused back into the patient. This infusion of T cells that are genetically modified in patients with scleroderma or autoimmune disease results in a very deep B cell depletion. So this is sort of a complicated slide. The top row is showing sort of normal lymph node architecture. On the left is the H&E staining, just sort of looking at the cells under the microscope the way a pathologist would look under the cells. The second column is CD19, third column is CD20, fourth column CD138, another dendritic cell. And so the CD19 and CD20 are B cell markers. And on the top row, you see inside the lymph node, the brown staining, are B cells inside a lymph node. This is a sort of a patient's lymph node before the CAR T infusion. 1 month after the CAR T infusion, a biopsy of another lymph node after the gene-modified T cells, we see 0 B cells in the lymph node and a complete disruption of the lymph node architecture. And it's that in the lymph node, B cells talk to T cells, and they signal each other, and and in a scleroderma patient, it's sort of providing this ongoing signal of attack and destroy the lung and cause fibrosis, and that is deeply disrupted in the patient that's gotten the CAR T cell. The bottom row is showing a patient who just got rituximab, anti-CD20 antibody, and at a month after the rituximab, there are no B cells in the peripheral blood, but the brown is staining B cells in the lymph node. So the rituximab doesn't deeply deplete B cells in the patient. The CAR T cell that's against the B cell does. And so we think that this will be a way of profoundly altering the immune system of a patient and generating a reset of the immune system in a patient with autoimmune disease, this deep B cell depletion. So the preliminary data that have emerged from a group in Germany, in Erlangen, which is near Nuremberg in Bavaria, they came out with a report about a little more than a year ago in the New England Journal of Medicine, initially describing patients with lupus, scleroderma, and myositis. And here's a little more detailed information on the 6 patients with systemic sclerosis with scleroderma treated with these CD19 specific CAR T cells. In graph A, you see basically a decrease in the modified Rodnan skin score. So the high score is bad skin fibrosis, tethered skin, and all of the patients had an improvement in their skin score. So the skin became less tight, less thick after the CAR T cell infusion. It's not 100% down to normal. It's not completely normal, but it's a substantial improvement. The other factors that also improved was digit ulcerations, the lesions that occur in patients in the fingers with scleroderma, healed and improved after the CAR T, and other markers of dexterity, of functionality, of quality of life improved in patients after the CAR T. So these are preliminary data that suggest that maybe after CAR T cell infusion, there can be substantial improvements. Other data also recently emerging suggests that the lung function studies are also improving. The PFTs, the pulmonary function test results, are recovering, and that there's less fibrosis in the lungs after the CAR T therapy. So these are only 6 patients, but there have been several other scleroderma patients that have received CAR T therapy, and there are many trials currently underway. We have three studies for scleroderma patients getting CAR T cells at Northwestern, and I have already enrolled patients in the study, and one patient recently is already now 4 months out. This was a patient who was 60 years old, who had a significant scleroderma, really advanced scleroderma for about 2 years diagnosis, with pericarditis, cardiac involvement, and she was too ill to take to stem cell transplant. and she's had a remarkable response to CAR T cells, and is off all of her immunosuppression medications and doing much, much, much better than pre-CAR T. So I have many more patients coming in for CAR T therapy, and I look forward to studying and learning from them how they do with this new treatment. The patients these 6 patients from Germany treated with CAR T, all of them had reduction in autoantibodies. So there's abnormal antibodies, abnormal proteins in the blood that occur in patients with scleroderma, and they disappear after the CAR T therapy. So CAR T is, let me summarize it again, just to sort of take you through what can happen and also take you through some of the complications that can occur. It's not without risk. Basically, we begin with screening patients and consenting them to participate in the research study. The sponsor pays for all of the cost of the treatment. The treatment is free. First, we taper off the MMF, the tocilizumab, for about a week, and then the patient undergoes apheresis and collection of the T cells. The cells are then brought to the laboratory, genetically modified. While that gene modification manufacturing is occurring, patient goes back on MMF or toci or nintedanib or whichever antifibrotic drug they were on previously. When everything is ready, when the cells are ready, they've been tested, ready to go, and we have a good number of them, we then again taper off the immune suppression, and we then administer lymphodepleting chemotherapy. Now this involves a combination of chemotherapy, fludarabine at fairly low doses for 3 days, with cyclophosphamide also at a fairly low dose, a substantially lower dose. In the patients that have had the CAR T so far, there's been no hair loss after they didn't go bald after the high-dose chemotherapy. And so the CAR Ts are then infused. I have the patient stay in the hospital for 14 days so that we can watch for potential complications. The patients typically develop a low blood cell count, what's called neutropenia, during this time. They're protected with antiviral, antifungal, antibacterial medications. And there's a risk of something called cytokine release syndrome, fever, low blood pressure, inflammation that occurs after excited gene-modified CAR T cells go in and kill all the B cells that can trigger a systemic immune response. And there's also something called ICANS, which is immune effector cell neurotoxicity syndrome that is also developed in a small number of patients, maybe about 10% of patients after CAR T therapy. So we monitor for that and treat it. Fortunately, we have treatment for CRS. We have treatment for neurotoxicity. The patients recover from the neurologic toxicity or the cytokine release syndrome and are released from hospital typically about 2 weeks after the CAR T therapy. And then we monitor for any other complications, mainly potential risk of infections. And so far, patients are doing well and recovering well from these infections. I would say that there was a recent report of a patient in Germany who was 9 months out after CAR T who died from pneumococcal pneumonia infection, emphasizing the importance for pneumococcal pneumonia vaccination after CAR T therapy because we have to rebuild and re-protect the patient from pathogens such as pneumococcus. So overall, the CAR T process is simpler than a stem cell transplant. Lower doses of chemotherapy are better tolerated. There are a risk of complications, but so far we've been able to manage or treat these complications effectively. So what are sort of the pros and cons for thinking about CAR T for autoimmune disease? I think it's a new, exciting, powerful treatment. There's a clear mechanism of action destroying the B cells in the patient, and it may be superior to the standard of care treatment for the autoimmune disease. I would say the preliminary data are promising, but I would emphasize that we do not have long-term data. We don't have the 11-year follow-up. These are brand new studies. We don't have 11-year follow-up demonstrating, like in transplant, the efficacy of stem cell transplant. Patients are achieving drug-free remission. This is a low-intensity treatment, much better tolerated than high-dose chemotherapy for stem cell transplant. There is probably, compared to patients with lymphoma, we see a lower incidence of the cytokine release syndrome and the neurotoxicity. The clinical trials are ongoing. We have active studies that are currently recruiting, and there's less time spent in the hospital, but there's still a time commitment for doing this. This is not just something that you can do from home. And there is, in younger women, there's concern that the low-dose chemotherapy might still result in sterility, inability to have children in the future, but in women in their 20s, probably not affected by this chemotherapy. And we can, importantly, treat patients with impaired organ function, such as cardiac and impaired lung function. And it involves a close collaboration with the rheumatologist. I would say the biggest con is that we don't know, negative factor of CAR T, is that we still don't know the long-term efficacy. It is possible that maybe the disease comes back after CAR T therapy. Phase 3 clinical trial data are probably not going to be available for many years. There's this risk of complications that I described, sort of alphabet soup of cytokine release syndrome, neurotoxicity, and lymphohemophagocytic syndrome. There are sometimes unexpected low blood counts after CAR T therapy, and sometimes opportunistic infections with low immunoglobulin levels. There's a risk for the disease reoccurring, and maybe a new autoimmune disease. There's an extremely low risk of T-cell malignancy that has been reported, I would say like less than 0.001% after patients getting CAR T for lymphoma. It's going to be expensive. Companies can patent the vector that's being used. They hope to make a lot of money in the future, offering, once this therapy is FDA approved. At the moment, it's free. And so hopefully, I anticipate with the good results, insurance companies will pay for this therapy. And there's a risk of death in doing this treatment, but I think the risk is low. And the potential, and it's important to carefully select patients for this therapy. So I've taken you through a kind of maybe too fast, maybe too complicated story of stem cell transplant definitely works. It's intense therapy, and new potential excitement for CAR T therapy, which so far seems to be effective with much less toxicity. Remains to be seen about the long-term efficacy. But we definitely need to change the therapy for patients with systemic sclerosis. I don't want to see 50% of patients with interstitial lung disease dead within 5 years of diagnosis. We really need to work hard to deeply alter the immune system, to reset the immune system, and therapy such as stem cell transplant and CAR T really offers the most promising approach to changing that, to avoid that inevitability for patients with scleroderma.